Hello friends and welcome again to the channel. I'm Dr. Mohsen Raj. I've done my MD from AIIMS New Delhi and now I'm a DM cardiology student at AIIMS New Delhi. This video is about the residency training that happens at AIIMS Delhi. I've done my training in the Department of Pediatrics, but by and large, a similar standard, a similar exposure every department provides to the students. And in fact, I'll make other dedicated videos on how there's, the condition in surgical branch as well. But medical branch, by and large, this is a standard of exposure that we get. So starting with the department that I've worked in was pediatrics. It had two dedicated wards. It had three HDUs, the high dependency units. It had one pediatric intensive care unit. It had three neonatal intensive care units, a daycare center, and a pediatric emergency. And all these areas together covered all the subspecialties of pediatrics. And what was interesting right at the start of this journey was that this department was about people who wrote the books. See, you all have read the Guy's Essential Pediatrics textbook in your medicine, in your MBBS. So the authors, when I joined, Professor V.K. Paul was the head of the department. Professor Arvind Bagga, he headed the nephrology division of pediatrics. Similarly, as you go through the pediatrics training, the benchmark of the NICU training is this textbook of AIIMS Protocols in Neonatology, again written by our faculty members. And in the pediatric intensive care, this is a standard text written by faculty of our department. So this way, so many different areas and so many different faculty members. We had training in almost every specialty that's possible in pediatrics. So I'll be giving a brief overview of what sort of an exposure we had during this pediatric residency. For example, if I start with nephrology, these three divisions form our Unit 1 of our Pediatrics Unit 1, nephrology, gastroenterology, and immunology, rheumatology. So nephrology, I'll tell you what a junior resident and MD resident used to do routinely in the nephrology ward. So this is not about what the DM persons were doing, but even as a junior resident, an MD resident in nephrology, what all skills did I develop in that ward? See, of course, I got to work up so many, cases, the routine garden variety AKI cases, the routine steroid-resistant nephrotic syndrome cases. That's a routine garden variety cases. But I got to see cases like atypical hemolytic uremic syndrome. I got to see cases, the rare tubular disorders, Bartter, Gittelman, and all those disorders in that list. Even some of the rarest diseases and the most severe forms of those diseases. I mean, we had exposure in plasma exchange or even all forms of dialysis. We as junior residents used to do peritoneal dialysis, of course, under the supervision of our senior residents, the DM residents. We used to do renal biopsies, ultrasound-guided renal biopsies, again, under supervision of the DM residents. And we used to put ultrasound-guided hemodialysis catheters in the jugular veins or the femoral veins under senior resident guidance. But as a junior resident, I've done all of this. Kidney biopsies, the hemodialysis catheters, and the actual performance of hemodialysis sessions and peritoneal dialysis sessions. Even all modalities of HD, hemodialysis, even things like continuous renal replacement therapies for the critically sick children in our intensive care unit. So we had a very comprehensive training of nephrology. And of course, under the supervision of Professor Bagga, we were all well trained. As I said, we learned from the authors of these books, and not just these small books. They are the authors of big journals and they have contributed chapters to so many international textbooks. Coming to gastroenterology, again in Unit 1, we had exposure. I mean, we were not seeing the routine cases of acute gastroenteritis and all those acute febrile illnesses in children. No. We had exposure in things like monogenic inflammatory bowel disease. I had written a series on infantile diarrheas, the intractable diarrheas of infancy. I've seen cases like microvillus inclusion disease or tufting enteropathy. And in fact, I had a case series of that same. I've written a protocol of how to manage intractable diarrheas of infancy. And those who are interested in that area could assist, could accompany the faculty in so many endoscopy procedures, upper GI, lower GI endoscopies. We manage so many patients with GI bleeding with the endoscopic treatment of those bleeding varices. Extensive exposure of gastroenterology. We attended clinics of celiac disease patients or IBD clinics as a separate uh, teaching and training. Immunology rheumatology was a smaller subdivision, but had very unique and interesting immunology cases. We've seen so many cases of juvenile dermatomyositis. I remember I had just seen a couple of them in my MBBS posting, and that in adult dermatomyositis. Juvenile dermatomyositis, some diseases which had 1 in a million prevalence. We saw them almost one every 2 months, one in every single posting in that ward. And of course, the other routine garden variety vascular disease like Kawasaki or even the rarer ones. Then coming to oncology, we had a very good training in oncology. The blood cancers, leukemias, lymphomas was a routine. And in addition to the various diagnostic testings, we, as junior residents, we were the person who was making these chemotherapeutic drugs, following the protocol of these chemotherapies, and actually administering the chemotherapeutic agent to the pediatric patient. In addition, an extensive uh, time was spent in dealing with patients of febrile neutropenias. Trust me, I haven't seen as many as acute febrile illnesses in children as I've seen febrile neutropenias. Febrile neutropenia is probably the most common febrile illness I saw in pediatrics residency. In addition, those sick patients with febrile neutropenia, septic shock, all those with multi-organ dysfunction. In addition, oncology covered a lot of daycare management. So, as I said, chemotherapeutic regimens. In addition, all the routine daycare procedures, bone marrow biopsies, intrathecal chemotherapies, they were all given by an MD resident, a junior resident, and of course, under supervision of senior residents. Pulmonology, again, was awesome. We saw cystic fibrosis is routine. The exacerbations of bronchial asthma is routine. The rare disorders like Cartagener syndrome or even surfactant protein deficiencies, all that variety was seen in the ward, besides the routine recurrent pneumonias and such stuff. Neurology, medical genetics, endocrinology was the unit 2 of our department, and it was again world class. You know, name a neurometabolic disorder that I haven't seen in my C5 ward, in my posting in neurology and genetics. Every variety of neurometabolic disorder. Obviously, in addition to the garden variety cases of neurology like tubercular meningitis or autoimmune encephalitis. I remember seeing patients of Moya disease in the ward. And I had a 2 month training in pediatric cardiology as well. And that's part of my current department, cardiology, but I had a 2 month posting there. So a good exposure that time as well. Now, coming to the intensive care training, all possible exposure in pediatric intensive care, airway management, central venous access, arterial line access, and in bulk, managing sickest of the sickest patients of all forms of shock and all forms of emergencies. That PICU protocol book that I just saw that I showed you in the first slide is not just written from the intensive care unit. It is actually practiced every single day in that unit. And the same is the story of neonatal intensive care unit. We are managed even as junior residents. Infants, extremely premature infants, 25 weekers, 26 weekers, 500 grammer infants. We have managed their delivery part, their resuscitation, and then subsequently their management in the neonatal intensive care unit. And again, that NICU protocol book is daily read, revised, and practiced in neonatal ICUs. You read that book, that's an awesome book of neonatology, but I haven't read it from the book. I've actually done it bedside. I mean, we had all forms of modalities available, even some of the rarer ones which you may not see in peripheries, like giving therapeutic hypothermia or giving nitric oxide therapy for pulmonary arterial hypertension. We've done almost everything in neonatology. In addition to putting all those lines and arterial and venous lines in small infants. Daycare, I've told you, It was more of an oncology part where routine pediatric cancer patients would come for their chemotherapeutic administration. We would prepare the chemotherapy and administer it. Intravenous, intrathecal, all forms, or bone marrow or CSF analysis were done by junior residents of pediatrics. In addition, the patients of genetics for their enzyme administration, yes, almost every enzyme that's available for a biogenetic disorder. A genetic disorder is available at AIIMS, and we used to administer them to these agents to these patients. Now, besides this, a bulk of clinical exposure, what was the standard of academics? Of course, we had bedside teaching with the faculty, everyday rounds with the faculty members, and those were the gurus of their branch, the international leaders of their particular division. In addition, we had a separate round. We had separate rounds with our DMSR, so that would mean a two-step learning process: a round with our DMSRs, a round with our faculty members. In addition to that part, we had daily morning academics, daily 8 a.m. to 9 a.m. class, sometimes even 2 classes a day, sometimes intra-unit class, sometimes an intra-departmental class. So it was extensive. All forms of teachings, faculty sessions were there, long seminars by junior residents, short seminars by junior residents, journal clubs by junior residents, even sometimes senior residents and faculty members, also all forms, mortality meets. There was extensive focus on academics. Every single day, there would be a class, and the class would be attended by all the residents and all the faculty members, trying to impress on the key clinical things, even the new changes in guidelines and such stuff. Research was everywhere. It was every day and everywhere. And in a few months of joining AIIMS, we had a proper research methodology course, 5-6 day long course, in which I was freed from every clinical work. Just go and attend that course. And even throughout those 3 years of MD training, I would watch. I was doing a project. My other colleagues were doing a project. I was doing a cohort study. Some of the other colleagues were doing randomized studies, a junior resident, an MD resident doing randomized controlled trial, and subsequently getting published in the journals. My thesis got published, and almost everyone's thesis gets published. In addition, you watch the DMSRs doing a little bit higher level of research. And of course, you would see faculty projects every day. For example, routinely working in PICU, I would be knowing that, yes, there's a project going on septic shock, the type of the fluid, or there's a project going on sepsis, like on procalcitonin. So I would be knowing what all research is currently going on. How is this research being actually conducted every day? I would watch my DMSR open that sealed packed envelope of a randomized trial and randomize a patient into one of the 2 arms of his study. So it was actually seeing research every single day. And in addition, a unique thing about our training was the easy availability of imaging. All of our wards and ICUs had sometimes 2 echo machines or ultrasound machines, if not 1. So which means I had access to an ultrasound machine or an echo machine whenever I needed. And that way we learned to do all these basic, of course, we wouldn't learn all of the ultrasound and echo, but we did at least do those point of care use of these imaging modalities. Bedside and in every ward and intensive care unit. And besides, of course, the availability of tests at AIIMS, imaging, blood tests, every form. Think of a test and it's available here. But towards the end, I'm going to focus on the fact that it was not just academics, it was not just clinical training. AIIMS is a lifestyle. AIIMS is a community that lives together. This is my badge of, this is the photo at the joining, the top one. This is the photograph when we passed MD Pediatrics. And there were lots of outings, lots of, and this is, by the way, one of my batchmates with one of my seniors. These 2 batchmates were from Nepal. One of my seniors, this is a picture at NCI Jajjar, which is National Cancer Institute. We were posted for COVID duties there at that time. And my senior is currently pursuing DM in medical oncology. Wonderful messes, and the food quality is unfortunately degraded from those days. This is a photo we clicked. All of these are my batchmates. This is near the convergence block at AIIMS. This was on the day of our exam, just after we finished the exam, a mandatory get-together photographs. Usually after days rigorous work, obviously it would be someone's birthday, and we would not miss a chance to celebrate a full day of extensive work, and then we would find time to celebrate someone's birthday or maybe attend someone's marriage ceremony. This was one of my seniors' marriage ceremony at Jaipur, and these are all my seniors from who are doing DM neonatology. And of course, things would be stressful as well. This is one of my batchmates this is the exam day. He was waiting for his turn of the Viva, an extremely bright student. He was, in fact, the one with, he had the, initial rank while we were choosing the MD Pediatrics branch. He had a rank of 9, All India rank of 9. And this is he waiting for his Viva. He was not that confident, of course, from this picture, but ultimately he did awesome in the exam. This is again the day of after we passed the MD Pediatrics, the enjoyment we had. This was one of my batchmates' room. This was a farewell just before we left. That was a COVID period, so it couldn't be done offline. It was done online, and these were some of the comments I had from my juniors. So overall, what I wanted to highlight is the exposure, the comprehensive nature of the training of MD residents at AIIMS. I specifically talked of pediatrics, and I'm sure this is the same standard in other departments, and I will try to interact with some of my colleagues in other branches who will give you an idea of residency in other departments of AIIMS. I hope you liked the video, and I hope some of you would definitely study hard and target for your residency, for your MDMS at AIIMS. If you like the content of the channel, I would appreciate if you subscribe to it, like and share the videos. Thank you.